Emergency departments face unpredictable patient arrivals, limited resources, and increasing congestion. When demand exceeds capacity, waiting times rise, and some patients leave without ever being treated. How can hospitals better understand and manage this? To see how these challenges unfold in practice, we simulate the flow of patients through an emergency department. The simulation begins here, at the patient arrival block. Patients are generated using a non-stationary arrival pattern, averaging 60 per day, with higher rates during peak afternoon hours. Each patient travels to the C's nurse station, where they wait in the waiting area queue until one of 2 triage nurses becomes available. The nurse takes approximately 3 minutes to assess the patient, after which a triage level is assigned and their icon is color-coded by severity: red for immediate, yellow for urgent, and green for non-urgent. Once triaged, patients enter the bed queue, waiting for one of 15 available beds. After securing a bed, they travel to the doctor queue, where they are prioritized by triage level. The most critical patients are seen first. The department has 4 doctors on duty. If non-critical patients wait longer than 4 hours at either queue, they leave the system entirely, captured by the left without being seen sync at the top. You can also see the cardiology and orthopedics queues below, which come into play after treatment. Once a doctor is seized, treatment begins, with duration varying from as little as 5 minutes for non-urgent cases up to 2 hours for the most critical. After treatment, each patient reaches the imaging branch. Here, a discrete distribution determines whether they require an X-ray, 30% do, while the remaining 70% skip imaging entirely and proceed straight to the department branch. For those needing an X-ray, they travel down to the C's X-ray block, where they wait in the X-ray queue for the single available machine. Each scan takes 15 minutes. With only one machine serving all patients, this station is a potential bottleneck. Once the scan is complete, the X-ray resource is released and the patient rejoins the main flow at the department branch. After imaging, the doctor releases the patient and they reach the next step branch, which routes them based on their assigned department. Non-urgent level 4 and 5 patients are sent along the general path, labeled Go Home, and proceed directly toward discharge. The more critical patients, levels 1 through 3, were assigned a department earlier during triage, with a 50-50 chance of being referred to either cardiology or orthopedics. Patients routed to the cardiology ward seize one of 5 dedicated beds and stay for 4 hours. Those sent to orthopedics occupy one of 8 beds for a 2-hour stay. On the left side, you can see the seize and release blocks managing bed allocation for each ward. Once the ward stay is complete, patients are released through the finished cardio or finished ortho conveyors. All patients, whether from the wards or discharged directly, then pass through the patient flow stats block, which records their total time in the system. Finally, the entity logger captures each patient's triage level and state durations before they exit at the discharge sink. Here we see the complete model running end to end. Patients arrive from the left, flow through triage, queue for beds and doctors, branch through imaging, route to the appropriate ward, and finally exit at discharge. Along the way, distributions govern arrival rates, triage levels, treatment times, and routing decisions, while resources constrain capacity at every step. Together, these elements capture the complexity of a real emergency department, letting us measure performance, identify bottlenecks, and test improvements in a safe, virtual environment before applying them in practice. Thank you for watching.